Hello, everybody. It's always wonderful to come to the Patient Care Conference. I've been coming here for, I don't know, more than a decade, and I have so many of my patients and families and friends here. It's just great to see you all. And thank you for being kind enough to invite me again. My talk is more about today, not necessarily what we hope for our patients in the next year or 5 years or 10 years. I'd like to be put out of business. And as a surgeon, I've been looking after children with EB for more than 27 years. And it's become a lifelong passion. Let me just describe a little bit about what esophageal strictures are in these patients. Unfortunately, this affects so many of our patients, especially with recessive dystrophic EB. And I'm going to talk a little bit about the current treatments that are being used, where we're successful and where we're not successful. So what is an esophageal stricture? It is a scar and a narrowing of the esophagus that impedes the ability for us to properly swallow. And so that makes eating solid foods particularly difficult, but sometimes even liquids or saliva have trouble getting past these narrowings. The scar involves the lining of the esophagus, not the muscle itself. So this is a disorder that is just like your skin. It affects the surface mucosa, but not the deep muscle. And that's different from other kinds of esophageal strictures that we see in patients with chronic reflux or have other diseases where the muscle is also affected. These patients frequently have painful swallowing and difficulty in swallowing, and the food lodges at these strictures, and many of the children chew their food well, but it takes longer and longer for them to eat. And eventually you end up with such a small opening that even very, very finely pureed foods are difficult to get past those narrowings. And in some of our patients, even saliva hangs up, which then is a real issue. It's a life-threatening problem for those patients. So there are a lot of issues when you have esophageal strictures. Coughing and aspiration, chronic lung disease can develop when you aspirate. These patients may end up with disorders of abscesses in the lung, other kinds of problems that are related to the strictures and aspiration. Most commonly, though, weight loss, dehydration, nutritional failure are the most significant common problems that we see. This leads to growth disturbances analogous to the puppies that you saw in Mei Chen's talk about the affected animals are much smaller than their litter mates that do not have EB. And also, mealtime becomes extremely protracted for many of the families, and it's very difficult when you have members who are finishing their meals in 20 minutes, and the child may need an hour, 2 hours, 3 hours to complete a meal. And so it changes the dynamics in the family significantly. This is actually a very old slide, but it goes back to Dr. Joe David Fine's work with the EB registry, and this data is over 30 years old, but it really hasn't changed. And the bars that you see, the top 3 are types or subtypes of recessive dystrophic EB, and what this shows you that over time, the majority of patients with recessive dystrophic epidermolysis bullosa develop strictures. Most of them certainly by adolescence, but we see children with strictures as young as 18 months of age, and they can have significant growth failure as they're presenting a symptom. You notice in the bottom lines, These are other types of epidermolysis bullosa, including junctional and EB simplex. The incidence of strictures in those populations or subpopulations are very, very uncommon. We do see them, but they're very rare. So over 90% of the patients who have strictures have involvement of the proximal esophagus. And when I talk about the proximal esophagus, this is the very upper part of the neck, just essentially below the Adam's apple. And 60% of the patients have involvement of just one site, but 1/3 have 2 significant strictures. And the remainder actually will have 3 or 4 or even more strictures, as you can see on the image on the right there. There's multiple strictures. Now, one of the discouraging things is that some of our radiologists around the country, when they're doing the barium swallows, they have a technician do the barium swallow. They're actually not physically present when the child is taking the barium, and they often miss the cervical stricture. And so we often get reports that the child has had a barium swallow, is having severe dysphagia, is losing weight, and yet the report is normal from the outside institution. So when we repeat those studies, we actually find a high-grade stricture, usually just at the beginning of the esophagus, and in an area that we call the cricopharyngeal muscle sphincter. And so this really requires a very careful review. And in some cases, I won't repeat the barium swallow only because the child will aspirate during the process of doing the barium study. And I will actually calibrate the esophagus with the balloon catheter that I'll show you later and really determine how significant the stricture is. So how are these strictures treated? And what are the long-term consequences of dilating these strictures? And are there some options for maintaining adequate nutritional support when the dilatations have limited effectiveness? And some of the patients clearly have limited effectiveness with dilatation. So unfortunately, even though I've been proselytizing the techniques that are minimally invasive and minimally traumatic for patients for more than 2 decades, many of my colleagues have not adopted these approaches in institutions that are of significant academic repute, and that's, they feel that they know best, and they're not willing to adopt these appropriate approaches. So they still do blind bougonnage with these large dilators and cause tremendous frictional injury to the esophagus. And also some of them use rigid esophagoscopy and also with bougonnage. These techniques are really contraindicated today for these patients. So I only mention them so that if you're in a situation where your doctor who has not had experience with EB patients and is recommending dilatation, not to allow them to do that to you or your child, because this creates long-term damage that may be irreparable. So many of the gastroenterologists will do dilatations. Their tool is a flexible scope. I don't have a problem with the flexible scope, but there are some limitations with what they can do with flexible endoscopy and balloon dilatation. First of all, the balloon size is often smaller than what you can do with the technique that I'm going to describe to you. And so they are often limited in the effectiveness and the duration of the effectiveness of the dilatation because the balloon size they use is far too small, often for the patient. The other thing is that the friction that's caused even by a lubricated scope can be enough that it causes sloughing of the entire esophagus, and it's taken patients 4 weeks to recover from such a dilatation, where most of our patients are actually able to eat either that night or certainly by the next day and go home. So the technique that I use is a fluoroscopically guided dilatation technique. I use our interventional radiology suite, which has a really excellent 360-degree fluoroscopic capabilities, and so we can actually control the environment very well for our patients. And the technique is relatively straightforward. It's putting a very soft, flexible guide wire through a very soft catheter, either through the mouth or through the gastrostomy site if the patient needs what we call a retrograde approach. And then we position the balloon at the appropriate site of the strictures. We can actually calibrate the entire length of the esophagus, so we map out, if you will, where the strictures are, so we know for future dilatations where to exactly go and be relatively atraumatic in the process. So we don't dilate the entire esophagus, we just dilate where the need is. And we do use general anesthesia for these. Some of our patients have an endotracheal tube placed, but as patients get older, some of our patients have such a small mouth, we call it microstomia, their tongue is fused. It's very difficult for intubation. They can do fiber optic intubations, but if those individuals have a gastrostomy tube, we can do a mask ventilation and actually dilate retrograde through the gastrostomy site, really creating minimal trauma for the patient. And it just allows them to feel much more comfortable when they wake up. We don't use an endoscope. Everything is controlled by fluoroscopic or X-ray control. We minimize the amount of X-ray the patient actually gets, because we can literally just tap the fluoroscope for half a second to get the image, and so the amount of radiation our patients get during the process is very minimal. And this is really minimally invasive, and you can see how the dilatation is very effective to get to a caliber that's appropriate for the patient's size and weight. We often put a little bit of water-soluble contrast in the esophagus afterwards, just to make sure there's not an injury to the esophagus. My biggest fear, and this is, I always transmit this to our families, that we can damage the esophagus further with a dilatation, especially if the scar is very dense and has been repetitive dilatations. Although personally I've never had a perforation of the esophagus, I still worry about that, and I receive patients who have had perforated esophagus from dilatation. So this is something I do worry about, but we're very gentle in how we do this. So what are the difficult situations? Very severe anemia is a real problem for these patients. And sometimes the children have behavioral issues. You cannot draw their blood ahead of time. We're looking at ways to get non-invasive monitoring of their hemoglobins, because we have had one child who had a cardiac arrest on the table during induction because of severe anemia. And this child this is one of the most difficult things that we've ever dealt with. But we are very concerned about very severe anemia in these children that would make them at high risk. Those that have very small mouths that make it difficult for the procedures to be done, not from my standpoint, but from the intubation standpoint, or if they require dental rehabilitation and care, this makes it very difficult to care for those patients. We've had one patient that had such a traumatic dilatation in another institution at age 9 that he refused to have any other dilatations done, and he came to see me about a year ago, and his entire esophagus was closed off. There was no opening, no lumen at all, and that becomes obviously a very difficult situation. And there are only a couple of options in that situation where we can actually salvage that. And so we do use a variety of tricks and techniques to deal with these difficult problems, and we can manage most of them, but it is not a simple process for the patient or for the care team. We do use a dose of steroids during the procedure. We find that when we have biopsied these children at the stricture sites, they have some inflammation. And so Decadron is a drug that's used to decrease inflammation. It's used in a variety of conditions. And so we do give a dose of Decadron prior to the dilatation procedure. We also provide some liquid prednisolone post-operatively for 5 or 6 days in most of the patients. Some of the patients have asked me not to give it because they get some side effects that they don't like. Some of them get hyper, some of them have extreme irritability, and some of them like it because their appetites improve. So I would say 90% of the patients do get steroids post-operatively. Now, we don't know the actual incidence of reflux, but I can tell you that it's significant enough in these patients that empirically I treat almost all of them with a proton pump inhibitor, as Dr. Farrell was describing in his talk yesterday. This is important because if you do not have acid suppression, if you particularly have lower strictures and reflux, those invariably get worse, and the interval of time becomes shorter between dilatations. So making sure the patient has an appropriate proton pump inhibitor. We use Prevacid a lot because of solutabs, and they're easy to manage for most of the children. Now, so what have been our outcomes over the last 20 years or so? And where we have really good records is more than 175 children that I've treated in Cincinnati alone. We have experience with probably another 40 or so patients outside of the U.S., and I have experience with patients in my previous positions in UNC in Buffalo, and these are not included in these results. But in Cincinnati, we've done more than 500 dilatations. The balloon size that we use, depending on the size of the child and the age, is 14 millimeters to 22 millimeters. The majority of the patients get immediate relief of their symptoms. Most of them are able to resume their diet within 24 hours. Complications are rare, but they do happen. We worry about anesthetic issues, aspiration, and esophageal injury as some of the things that we worry about. Although those rarely occur, it's still, we're on our toes and we're not complacent about those issues for those patients. And the interval between dilatations is very variable. Just like the skin manifestations of our patients are quite variable, some of the patients need dilatation very frequently, and other individuals may go 8 years and not have a problem. So the majority, though, require dilatation at least every 13 months. That's the average of our patients. So what happens when dilatations are not able to support the patient adequately? So gastrostomy is an important part of the armamentarium that we use. When patients require frequent dilatations, it provides a clear safety net so that if they do get obstructed, that they can get adequate hydration and nutrition. When there's significant eating behavioral issues and the dynamics in the family are not healthy, this improves that. I would say that in our practice, virtually half of our patients now have gastrostomies. The ones that don't tend to have very good nutritional status, and the frequency of dilatations may be once a year or once every 2 years for those patients. Those patients that are neonates that require gastrostomies are not that many, but some of our recessive dystrophic patients who can't feed properly because of mouth blistering, many of our junctional patients will fall into that category as well. So this is just to show pictures of the initial gastrostomy tube. I use a percutaneous non-laparoscopic technique, again in our interventional radiology suite. I'm not going to go through the details of the technique, but there's not a surgical incision in these patients, and it really has revolutionized our ability to easily care for them, and most of the patients go home by the third day after the procedure. So the techniques that we're using are really now the first line of treatment, at least in our practice. They're safe, repeatable, and successful. It minimizes damage to the oropharynx, eliminates an endoscope, it maximizes the esophageal diameter, and maintains the nutritional status of these patients, and it obviously improves their quality of life. Patients with EB and strictures have really lifelong issues in maintaining adequate oral nutrition. This non-endoscopic hydrostatic balloon technique is very effective in managing strictures, and it maintains a reasonable nutritional status for the patient. But this is not enough. So a variety of other techniques, including the gastrostomy, and procedures that I have not really gone into today, can enhance and prolong the quality of life for almost all the patients. So I tried to make this short enough so I could get questions from you all, and I'd be happy to address them. Thank you.
Questions?
Hi, we have some good doctors in Albany that seem to do the dilatations correctly. I do know that they don't like to go above 10 size balloon because they're just worried. I don't know if we should talk to them about maybe going up to a 12 or just trust that.
No, I think they should go higher because your children will have a longer interval between dilatations.
Yeah, he's getting maybe 3 a year.
Yeah.
And they put us on a treatment of budesonide twice a day, 20 packets of Splenda, but they've never sent us home on prednisone. What do you think about that budesonide treatment? And so, they're talking as if it should be for the rest of his life.
Yeah, I have not used budesonide personally, but you know, I know there are a couple of centers that are advocating that, and I don't have a problem with it, but just like a lot of things in EB, it's empirically done. It's not based on you know, a trial that's been done or evidence-based. I think all of us have sort of tried things by sort of trying for one patient and seeing if it worked, and if it didn't work, trying something else. And so that's how I learned how to take care of patients with EB, is by trial and error.
Other questions? Over here. I was wondering what your thoughts would be on maintenance dilatations. Our doctor wants us to come back every so often just to make sure that it doesn't get bad.
I can tell you that some of our families know, just based on their child's pattern, that they're going to need a dilatation at every 4 months or every 6 months or once a year, and they kind of plan their lives around that. The problem with maintenance dilatations in general for every patient is that you're probably doing more dilatations than you need to be doing. It's traumatic to go through, even if we do it nicely, gently, and compassionately. It's a huge deal every time the child is experiencing that. It's a huge deal for the family to come to the institution and go through that process. I'm not a big fan of routine dilatation on a sort of every 6 weeks or every 3 months, unless the child has symptoms that warrant that.
I had a question. If you have a child who has to go for a dilatation for the first time, how do you, and most of these children are young, how do you recommend talking to that child about what they're about to go through?
Well, it depends obviously on the age.
Say sub 10, between 5 and 10 years old.
Yeah, so I often enlist the help of the parents or the guardian in terms of understanding what that child's normal approach to physicians, procedures. Some of them are so traumatized from just bad experiences getting their dressings done. They're afraid of everything. They're afraid of needle sticks. So depending on the child, I'll sit down with the child and talk about the procedure in general ways that we're not going to try to do extra hurts. We're going to lubricate the masks. We're going to try to make this as painless as possible for the child. And I will tell them that they may wake up with a little bit of a sore throat, because they frequently do. And try to be honest with them enough that they recognize that you're not pulling the wool over their eyes. Because there's nothing worse than if you lose the trust of that child, they won't want to come back. And they'll resist every time. Even if you've done everything right and gently, they still may not want to come back, but which is understandable. But a lot of the kids that I've dealt with over the years, they'll tell the parents, it's time for me to be dilated. And they know that we have a good team, that we're going to watch over them carefully. They're not going to come out with lots of blisters where they didn't have them before. And everybody's very compassionate in our center dealing with these children. And so, where Dr. Lane was talking about 80 individuals, I think we probably, if I invited everybody to my home, it would be over 200 individuals in our center that literally care for these children and know how to support them.
We have time for one more question.
If the stricture is very tight, can it be harmful, and can you be overly aggressive by opening it all up? Should it ever be done in 2 different procedures?
Yeah, that's a very important question, and it depends when the patient is in their sort of life cycle of strictures. So the more dilatations that have been done, the more intense the scarring can be. So if you have a very young patient with a first-time stricture, the stricture is very soft and very easy to distend and get to a normal caliber. If you have somebody who's in their 30s and 40s and they've had 50 dilatations and they've been dilated in a variety of ways, those strictures may be much more difficult. And you have to sometimes do it in 2 stages, at least to test it out. If I'm seeing a patient who's been dilated in several centers before, I don't know what the integrity of the esophagus is like, and I don't know how hard the scar is. And so I may do a much smaller dilatation in terms of balloon caliber and get a feel of how much pressure. We have a manometer that we actually can measure the amount of pressure it takes to distend the stricture. And so if the pressure is more than 2 atmospheres, I worry that the scar is much more rigid than you would want. And so I may do that patient in 2 settings or 3 settings to get up to the proper caliber.